This PowerPoint presentation is on the topic of promoting healthy hearing over the lifespan. As I mentioned in my introductory comments, audiologists in many cases have an opportunity not just to manage a person's hearing loss once it has been acquired or once the person notices that they have a hearing loss. We also have the opportunity to actually prevent hearing loss or at least minimize the amount of hearing loss a person has. And that's the focus of this presentation. I didn't mention this in my introductory video, but I do have faculty appointments at various universities in the United States and elsewhere in the world. And of course, I do most of my teaching online. I can't be at all these different places at one time. I also lecture quite often, both in the United States and internationally, and I'm involved in several consulting opportunities which involve research. My email address is at the bottom of this slide. You may want to make a note of it in case you want to request some articles that I've written or perhaps ask me a question via email. I also have a website which you see there at the lower right-hand corner of the screen, audiologyworld.net, and you are welcome to visit that website. These are the topics that we're going to be covering today. I'm going to first talk about how promoting healthy hearing, trying to prevent hearing loss, is really a public health initiative. And audiologists really should, I think, start thinking more about preventing hearing loss as a public health issue, rather than, again, just seeing patients who already have the hearing loss. So we'll talk about that concept, how hearing and public health can intersect. I'm going to spend much of this presentation, and there's going to be two parts. This is part one, which will be approximately 1 hour, and then part two will be also about 1 hour. Part one will consider what I am referring to as comorbid conditions, that is, problems, health problems that may interact with hearing loss. Some of them actually can make hearing loss worse, and problems that can be affected by hearing loss, so vice versa. In other words, let's take dementia, for example, or cognitive function. A person may have some cognitive decline, but it can be made worse by a hearing loss. So these comorbid conditions are related to hearing, but they're not directly causing the hearing loss in most conditions. They're risk factors for hearing loss. And it's a very important concept, so we'll spend plenty of time talking about that. And then I'll cover really the heart of this whole lecture, the most important topic, and that is how we can promote healthy hearing of our patients and at the same time, therefore, be promoting healthy hearing. Healthy living and healthy hearing go hand in hand. And we're going to talk about lifestyle factors that have a big influence on hearing that you need to be aware of and need to take into account when you're counseling patients and when you're interacting with physicians and other health professionals who may take care of these health problems. I'm going to spend a good part of the lecture also on talking about how you need to expand your test battery far beyond pure tone audiometry in evaluating hearing in the most accurate way possible. And this test battery needs to include tests that are procedures that are very sensitive to any type of auditory dysfunction in the peripheral auditory system or in the central auditory system, and also are very specific. That is, test battery that allows you to pinpoint where in the auditory system the problem is. Now, simply relying on pure tone audiometry as your primary and most important auditory test will not accomplish that goal. We will talk in this lecture about expanding your test battery using existing tests that are out there that have been studied and are evidence-based, but using them in an appropriate way to evaluate your patients. Toward the end of the second part of this presentation, I'll actually present a couple of cases to show you how this approach, taking into account a person's comorbid conditions, health conditions, taking into account their lifestyle factors, and utilizing a very sensitive and specific test battery will allow you to effectively manage a patient, and in many cases, hopefully, prevent or mitigate hearing loss. And then at the very end of the presentation, in about 2 hours, I will be talking about how you need to really collaborate with other healthcare professionals, physicians, psychologists, and others to achieve this goal of preventive audiology. That is, preventing hearing loss through early detection of auditory dysfunction and very appropriate management of your patients. Much of the information that we'll be talking about in this presentation is included in a recent article that I published last year, 2021. It was actually published in an Iranian journal of audiology, a journal of audiology that's published in Iran, and it's entitled Promoting Healthy Hearing Over the Lifespan. If you're interested in receiving a copy of this article, I would be more than happy to send it to you. Just drop me a line. And I've also sent the article, the reprint, to the organizers of this conference who also might be able to make it available to you. Well, as I said, preventing hearing loss is really a public health initiative. It falls right within the concept of public health. Public health is the science of protecting and improving the health of a person or the health of a community. And as audiologists, we don't normally think about our work in this way. We don't really think about us as having an impact on public health. But as many of you know, hearing loss is extremely common. Tinnitus is extremely common. In children, otitis media and other hearing problems are not uncommon at all. Most pediatricians will see more patients with ear infections than any other type of problem. So we need to think about audiology and think about our work as being hand in hand with those public health experts that also are interested in the health and protecting and improving the health of people. So I've already talked about some of the ways we can improve hearing or prevent hearing loss, and they're totally in alignment. They're totally in agreement with the goals of public health. That is, promoting a healthy lifestyles, making sure that we know as much about the causes of hearing loss and how they impact hearing and how we can prevent them, or at least how we can detect the hearing problem at the earliest possible time to minimize its effect. So we can do this with individual patients that we see in the clinic, but we can also educate physicians, educate the public, educate policymakers in order to improve the hearing of large numbers, hundreds of thousands of people. We can do this by educating everyone about the dangers of noise exposure, for example, or the dangers of certain drugs that might be ototoxic, or by pointing out the connection between some systemic diseases, some very common diseases like diabetes and hearing loss. So think of yourself not just as an audiologist, but think of yourself as someone who's contributing to the public health of the population in Russia, in your case, and in my case, well, the United States and the rest of the world. Now, as we more specifically talk about how audiology can be directly related to public health, let's look at both children and adults, and the issues are somewhat different for those two populations. For children, a great example of audiology as a public health initiative is universal newborn hearing screening. With universal newborn hearing screening, the goal is to detect hearing loss by 1 month, to diagnose it accurately by 3 months, and of course to begin intervention for the child's hearing loss by the time they're 6 months after birth. Well, that's quite a ambitious goal, but we're now doing that in many parts of the world. And early hearing detection and intervention programs are a great example of audiology concepts being applied to public health. Because EDI programs, that's what the abbreviation is, early hearing detection and intervention, will actually improve a person's life. They'll actually improve a child's academic abilities, their emotional status. They'll be able to achieve more in life. So EDI programs, early hearing detection and intervention, is a good example of public health in audiology for children. The same goes with reducing ear infections. Ear infections can be minimized, they can be mitigated. And through education of physicians, mostly pediatricians, we can really improve the lives of a lot of children. Smoking in the household, we know, is a risk factor for ear infections. So is being around other children in a daycare facility. We know that breastfeeding of children is more likely to reduce ear infections. So there are ways we can minimize ear infections and therefore minimize hearing loss in infants and children, or, of course, detect them as early as possible using techniques like tympanometry so the ear infections can be best managed. And then, even though we think of noise exposure as being mostly a risk factor for adults, the research clearly shows that children, particularly when they get into the school age years, children can be definitely at risk for noise-induced and music-induced hearing loss. So there are ways for us to apply public health principles to audiology in children. Now, the greatest opportunity for improving or preventing hearing loss and mitigating or reducing the impact of hearing loss is in the adult population. Noise-induced hearing loss, we've just talked about, is a very good way to do that. The vast majority of hearing loss etiologies in adults, that is the cause of hearing loss in adults, the vast majority, well over 50%, involves either noise exposure or age-related factors, which we're going to talk about in this presentation. So, we literally have an opportunity to prevent or mitigate, reduce hearing loss in the majority of people that are out there, in the majority of the adult population. We can also, as we're preventing hearing loss, prevent tinnitus, or at least prevent bothersome tinnitus. And so that's kind of the focus of this whole lecture. It's a different way of looking at audiology. And I think you'll find that it actually is a very stimulating and very positive way of looking at audiology. We're not just performing basic hearing tests on people who already have a hearing loss. We're actually taking a much more important role in the healthcare community. Now, if you look at the literature, if you go to do a literature search, you'll find that this is becoming a hot topic. I didn't just make this up. You will find articles like this one here by some audiologists in the United States. How can public health approaches and perspectives advance hearing healthcare? So I encourage you to check out some of these articles. Interestingly, almost all the articles on public health and audiology and on the impact of comorbid conditions that we're going to discuss on hearing, almost all of this literature has been published in the last decade, in the last 10 years, since around 2010. In the United States, there is a public health initiative that is kind of updated every 10 years. So now we're looking at Healthy People 2020. We're only a few years into that decade. And if you check out this website, healthypeople.gov, you will see that audiology and hearing problems are take an important role in current efforts to keep people healthier. Here is a table. You're looking at a table from Healthy People 2020. And even though this is a website from the United States, is a government website from the United States, this information is not limited to one country. So there are audiologists interested in public health initiatives in audiology, preventing hearing loss, minimizing hearing loss throughout the world. A lot of the literature actually is from Australia, the UK, and other places. So I would encourage you to be among the first audiologists in Russia to take this approach and utilize this information in your clinical practice and in your education of other healthcare professionals, the general public, policymakers, and if you teach, educating your students. So if we look at the list of the different types of health concerns or health initiatives that we should be thinking about, and this is straight out of the the website that I just showed you, you can see I've highlighted in red the different colors, the different disorders that are directly related to hearing. Arthritis, heart disease and stroke, we're going to talk about these in a moment, comorbid conditions, chronic kidney disease, diabetes, cancer, dementias. These are all connected to hearing. And of course, prominent in this list of examples of how we can improve the health of people over the lifespan is hearing and communicative disorders. Okay, so I've been talking a little bit about comorbid conditions. Let's spend a little more time now on that topic. And it is a very, very critical part of this lecture. So the more you learn about comorbid conditions, the better you'll help your patients. And of course, the more you'll interact with other healthcare professionals. In the United States, two audiologists, Ian Windmill and Barry Freeman, some of you may have heard of them, they've conducted several studies. Now these data, and I'm going to explain them right now, they're from older adults in the United States. And by older, I mean 65 years and older. In the United States, many people have private health insurance. But as you age and you get over the age of 65, most adults, like me, will opt or choose to have some health insurance from Medicare. Medicare is a government health insurance or organized health insurance plan. Now, usually it's supplemented with other plans. So Ian Windmill and Barry Freeman had access to Medicare data. So these are data on health insurance, reasons for older adults to seek health care using Medicare as their health insurance. Well, we're not interested in health insurance, but we're interested in the data. And what you can see with this graph, it's a bar graph, is that if you look at the patients coming to see audiologists, patients who are over the age of 65, they've got all kinds of health problems. They're coming in maybe because of concerns about hearing, or maybe their family members are saying, well, you need to do something about your hearing. So that's why they're going to see the audiologist. But it turns out, if you look at their medical records, if you look at the Medicare data, they've got all kinds of other health problems. And we're going to talk about some of these. Some of them are problems related to cardiovascular health and disease, like hyperbilirubinemia, high cholesterol, for example, or other problems such as heart attack or stroke or high blood pressure, hypertension. Some of the problems are other systemic problems. Kidney disease, you wouldn't think that'd be related to hearing, but it is. Arthritis, autoimmune diseases. Some of the problems that people have, these are medical conditions that they have, which people have considered unrelated to hearing. Well, in fact, they are related to hearing. And they include, for example, reduced cognitive function or dementia. So if you're evaluating an older patient in your clinic, the chances are very good that that older patient doesn't simply have a hearing loss, they have other health problems that are directly related to that hearing loss. So we need to consider these comorbid conditions. It's very important that we always ask patients about their general health, and we understand the relationship between these comorbid conditions and hearing. So there's literature on this as well. And these articles, and the little red arrow points to the year, you can see these are within the last 10 years. Comorbidity in adults with hearing difficulty. Well, what chronic medical conditions are related to hearing impairment? This is just one of dozens of articles exploring comorbid conditions in hearing. Well, in this article, it was a relatively small group of subjects, 1,900. Some of the studies have actually hundreds of thousands of subjects. And they were patients or subjects over the lifespan from 18 years to 70 years. And these authors identified diabetes as one of the top comorbid conditions related to hearing. So we're going to talk quite a bit more about diabetes now. But they also identified others. In fact, that list is shows all of the comorbid conditions that they considered. So we're going to delve into this in a little more detail right now. If you ask me, if I were there with you in St. Petersburg and you were to say, what health problem, what common health problem is most closely connected to hearing loss, I would have to say diabetes. So I would say that if you are seeing adult patients, particularly older adult patients, 50s and their 60s and 70s, even in their 80s, very often you are encountering patients who have been diagnosed with diabetes or they're pre-diabetic. Now, some of them may be obese, some of them may have other comorbid conditions like high blood pressure that can be associated with diabetes. Well, any of these patients are at great risk for hearing loss. So we're going to talk at the end of the 2 hours about how you should interact with primary care physicians. But one thing you should do is always educate primary care physicians about this connection between diabetes and hearing. And you should always ask your patients in your general history about diabetes. And if they are pre-diabetic, if they are being treated for diabetes, you need to understand that that's one reason they have a hearing loss. And anything that can be done to manage the diabetes actually will prevent some degree of hearing loss. And this is a problem, certainly in the United States. Obesity and diabetes, they go hand in hand. It's becoming a bigger, and it didn't mean to use a pun, but it's becoming a more serious problem all the time. So let's look at the literature on this connection between diabetes and hearing. Well, a lot of the literature actually now involves many, many studies, either big studies, individual studies, or the compilation of data, the collection of data for many, many studies, all analyzed at one time. And so there are many what are called meta-analyses, analyses of data from many studies, or systematic reviews of many studies on the same topic, in this case diabetes. So this study involves almost 140,000 women. So just one gender, women, but a large number. And it's only self-reported hearing loss, people who think they have a hearing loss. Now, as a rule, there are many people who don't think they have a hearing loss who really do. And we've all run into them. You may be such a person. You know, you're an audiologist. You evaluated your own hearing, or someone did, and maybe you were surprised to find you actually had a hearing loss because you didn't think you did. So this is really underestimating the hearing loss if it's self-reported. And yet there was a direct connection between type 2 diabetes. That's the type of diabetes that you acquire in adulthood related to obesity and other factors, not childhood diabetes. And the longer someone has diabetes, the more likely they are to have a hearing loss and the more serious that hearing loss. So this was one of the earlier studies linking diabetes and hearing, and there are dozens and dozens of such studies. Here's another one. Hypertension, which is a comorbidity of itself. If a person has high blood pressure, they're more likely to have a hearing loss. They're also, of course, more likely to have hypertension if they have diabetes. And you put the two together, and that's even greater risk for hearing. And so there is an association, and this has been confirmed now, between hypertension, diabetes, and hearing loss in the elderly. So here's two risk factors and two comorbidities that we must always take into account when we're evaluating patients in our clinic. Here's another article, again, there are dozens, so I'm just pointing out some of them. Is there a link? Well, the title says, is there a link? But the answer was in the article. Yes, there is a link. Diabetes and hearing loss are directly related. The longer the person has the diabetes, the higher the risk for hearing loss and the greater the degree of hearing loss. And there is even a group of audiologists in the United States called the Audiology Project. And this is a slide from one of their online materials. How can diabetes harm your ears? And this is the kind of initiative that I was referring to earlier. This is a public health initiative. Getting the word out to physicians and the public and anybody who will listen that diabetes is a risk factor for hearing loss. And the more effectively the diabetes is managed, the better the auditory outcome. So I encourage you to check out this website, theaudiologyproject.com. Their whole focus is on diabetes and hearing loss and making sure everybody understands that there's a connection. Okay, let's move on from diabetes to another common systemic health problem, and that's rheumatoid arthritis. Almost all of us know someone, maybe a family member or a friend or some acquaintance who has rheumatoid arthritis. And it seems like it's totally unrelated to the ears. It affects knuckles, joints, skeletal integrity, but it actually is related to hearing. There are articles clearly showing that when you take a person with rheumatoid, or a group of people with rheumatoid arthritis, and this is a study of over 18,000, that they're at great risk for hearing loss, and the older they are, the longer they've had the RA, the rheumatoid arthritis, the greater the risk. Now, we don't know, nobody knows exactly what the mechanism is. Maybe it has something to do with their immune system deficiency. Maybe it has something to do with the medication that they're taking for the rheumatoid arthritis. But one way or the other, it may be a vascular etiology, but the connection's still there. So we should always be asking every patient that we see, do you have any arthritis in your family? Do you have arthritis? Are you being treated by a physician for arthritis? Moving on quickly, and we could talk about any one of these comorbidities for at least an hour, but we're going to move right on to another study, and this is a systematic review and a meta-analysis. So this is a group of researchers that are looking at dozens of articles and many, many thousands of patients who have chronic obstructive pulmonary disease, COPD. Again, you wouldn't make the connection between hearing and a breathing problem. But in fact, there is a connection. And there's a greater incidence of hearing loss in patients with COPD than in a group of people without COPD. These patients may not just have cochlear hearing loss, inner ear hearing loss, they also may have central auditory problems. This systematic review showed that ABRs, auditory brainstem response latencies, are typically delayed in patients with COPD. Perhaps their brain is not getting as much oxygen as it should, and it's beginning to affect their central auditory nervous system function. So here's another comorbid condition that you must take into account. And now we're dealing with other physicians. Maybe we're dealing with pulmonary experts and people, of course, gerontologists, people who take care of elderly patients. So it's important to get the message out that this is another comorbid condition related to hearing. Kidney disease. I mentioned kidney disease earlier. The average person's not going to connect something happening in the person's kidney with something happening in their ears, but there's a direct connection. Now, we've known about this as we've learned more about ototoxic substances. Ototoxic drugs tend to be more ototoxic. They cause more damage to the cochlea when a person has impaired kidney function. The toxins are not being adequately removed from the blood. But this is in patients who are not taking ototoxic drugs. If, for example, someone with kidney disease is undergoing hemodialysis, they go in for dialysis treatments 2 or 3 times a week, they're much more likely to have a hearing loss. So we need to put this on our list of comorbid conditions. And we need to be talking to nephrologists and urologists and other specialists and physicians who take care of patients with kidney disease. Now, if you asked me, if I were there with you in St. Petersburg and you said, Dr. Hall, you mentioned that diabetes is a major comorbid condition associated with hearing loss, what would you put as the second most important, or right up there with diabetes as a comorbid condition with hearing loss. In other words, what health problem is directly related to hearing aside from diabetes? And I would say, well, there's no question in my mind that the three top problems, comorbid conditions related to hearing, are diabetes, cognitive function, and particularly cognitive decline, even dementia. And then the third would be cardiovascular disease, which we'll cover in a moment. Now, the connection between dementia and cognitive status, cognitive impairment, and hearing loss has only been appreciated for the last 10 years. And even at the beginning of that 10-year period, roughly around 2011, there was quite a bit of controversy. When these first studies, and this is one of the very first by Frank Lin, he's at Johns Hopkins Medical Center in Baltimore, Maryland. And when he came out with this article, Hearing Loss and Cognition Among Older Adults in the United States, it was a bit controversial. People criticized him. They said, no, we don't really think there is a connection between cognitive function and hearing. Well, since this article was published, dozens of other articles, dozens of studies, meta-analyses, and systematic reviews have been published, and the connection is unequivocal. There's no doubt about it. Hearing loss can contribute to decline in cognitive function and dementia and decreased cognitive function can make auditory problems even worse. In other words, a person who has a hearing loss will have even more problems communicating if they have cognitive decline or dementia. So this link is very clear, and this brings in a whole new group of physicians that we should be interacting with. Not only physicians that take care of the elderly, family physicians, gerontologists, but also neurologists and psychiatrists, and even non-physician health professionals like psychologists. So let's just quickly take a look at just some of these articles. I just showed you the very first article. Here's another follow-up study a few years later on hearing loss as a risk factor for dementia. Now, this is not just a single study. This is a systematic review. So when you tell physicians that there's a connection between dementia and hearing loss, give them an article like this and say, look, dozens of studies have come up with the same conclusion. So this is 17 peer-reviewed articles, only use pure tone audiometry, and then 2 measures of central auditory processing. This SSW test, now this was in the United States, that's the staggered spondaic word test. And then one of my favorite tests, developed by James Sturger, the SSI-ICM. Now the SSI stands for Synthetic Sentence Identification. So this is a speech perception and noise test. And the connection was very clear. Hearing loss contributes to dementia, and dementia makes a person have even more communication problems if they have a hearing loss. And if you do a search on these topics, like with key terms, a literature search like hearing loss, dementia, hearing loss, cognitive function, you'll find literally hundreds and hundreds of articles. So this is a rock-solid connection between hearing and cognitive function. And when you look at hearing loss, as identified with the audiogram, there is a connection with cognitive decline and dementia. So that's just the hearing loss itself. But when you actually evaluate central auditory functioning, using, for example, a speech perception and noise test, then the connection's even stronger. Obviously, the greatest connection between cognitive function and hearing will be for the most sophisticated hearing tests of auditory processing. And we're going to talk much more about that when we get to our diagnostic test battery. But this connection is so strong. And this is another meta-analysis and systematic review of 25 articles. The authors are from Nottingham in the UK. And what they found was there is a connection between cognitive functioning and hearing, and it's strongest, that connection is strongest, for cognitive function and speech perception in noise. Now, many of you don't have time to review dozens and dozens of articles in the literature. You're very busy and you have a limited time for research. So I would suggest that you just find a couple of these articles that we've already mentioned, the systematic reviews and the meta-analyses. So it's a good way of summarizing many, many articles instead of reading each article. And then here I found this very recent 2021 article, Hearing and Dementia from Ears to Brain, and I recommend it. It's a group of authors, some of whom are very well known in audiology, particularly in the area of auditory processing. Download an article like this. You can find it on the internet. It's open access, even though Brain is a very well recognized peer-reviewed journal. You can download the article for free, read it, and then pass it on to physicians who might be seeing patients, older patients who have cognitive decline or dementia. It's a great review article. It's very important for all of us to be up to date on this. If you graduated with some kind of education in audiology more than 10 years ago, you won't even be familiar with these articles. Now, we've talked about some of the major comorbid conditions in hearing: diabetes, kidney disease, rheumatoid arthritis, cognition, dementia. Here's another really important connection: dual sensory impairments, visual impairments, for example, and hearing impairments. We could have other sensory impairments, vestibular, tactile, other sensory impairments, but we're going to focus on vision and hearing. As we get into the older population, just as hearing loss is quite common, well, so are visual deficits. So anytime you have a patient in your clinic, you should not be just concerned about their hearing. You should be also thinking about their visual status. How's their vision? Now, we've known that vision will impact, of course, lip reading. If a person has a hearing loss and a visual loss, they're not going to get as much benefit out of watching a person speak. But here we're talking about another connection. We're talking about age-related vision deficits, for example, glaucoma, detached retinas, other age-related visual field deficits, age-related visual problems, and hearing problems. And when you put the two together, not only does the person have more problems communicating, they tend to be very discouraged and even depressed. So there is a high correlation between dual sensory impairment, untreated visual impairment, poor vision, and untreated or inadequately treated hearing loss, and depression. And again, the more hearing loss the person has, the worse their vision, the more likely they are to be depressed. So another group of physicians that we need to be interacting with, another group of health professionals, optometrists, ophthalmologists, people who take care of people with vision problems, have to understand that they could be related to hearing problems, and they both could be related to depression and psychological issues. Here's a systematic review of this very topic. So if you have to pick one article, this might be a good one to review. Dual sensory hearing loss is very prevalent in older patients. We know this. Hearing loss and visual deficits. And together, they reduce a person's sense of well-being. The person doesn't feel as healthy. They tend to be more isolated. They tend to not live independently. So we need to address this, and when we see a patient with for hearing loss, for a hearing evaluation, we should ask about their vision, and we should make sure that they're getting the same kind of care on the vision side that we're providing them on the hearing side. All right, I could go on and on about comorbid conditions, but we won't dwell on them. I do suggest that you read several of those review articles. In fact, some of you may want to take a collection of these review articles that are in English language and translate them into Russian and publish them in a journal that primary care physicians and specialists medical specialists in Russia tend to read. Try to educate your physician colleagues in Russia about the importance of these comorbid conditions and how they relate to hearing. Well, now we're going to talk about another really important topic when it comes to promoting healthy hearing over the lifestyle, and that is the connection between healthy living and healthy hearing. And this is going to be an eye-opener for some of you. Many of you, when a patient comes in, you don't ask questions about their lifestyle. You immediately evaluate their hearing and you determine whether or not they need amplification, for example. But we should be backing up a little bit. Before we even get to evaluate their hearing, before we get to that point, we should be asking the patient about their lifestyle, because the lifestyle can be changed. You may have diabetes and you may be unable to manage it without medicine, and even with medicine there may still be a problem with diabetes. But some of these lifestyles you can change. A person can stop promoting their unhealthy lifestyle or living their unhealthy life, and they can really improve their hearing in so doing. So let's go over this. What are some of these lifestyle factors that can influence hearing? Well, one is diet, what you eat. Diet is a major lifestyle factor that influences hearing. If we eat a healthy diet, fruits and vegetables, drink a lot of water, lean protein, not a lot of fatty meat, lean protein, fatty acids, we tend to be healthier. There's a direct link between diet and health. One of the easiest ways you can improve your health is to improve your diet. And at the same time, you're going to probably improve your hearing, or at least prevent hearing loss that is associated with a poor diet. Now, this connection is also very recently proven, the last 10 years, and it's solid, rock solid. Healthy diet will reduce the risk for hearing loss in women and men, and this is based on large numbers of studies. Here's another study. This is some colleagues of mine that I've worked with them. We've been faculty members at the same universities. Chris Spankovich is the lead author. Dr. Spankovich has a degree, 2 degrees in audiology, a PhD and a Doctor of Audiology degree, but also a graduate degree in public health. And so he's really focusing much of his career on this link between diet and other public health topics and hearing. And so here's another large study showing that poor diet is related to hearing loss and to bothersome tinnitus. So diet alone can be related to hearing, and then sometimes, obviously, diet or poor diet, bad dietary habits, can be linked to some of the comorbidities we've already talked about. For example, diabetes. Diabetes and poor diet go hand in hand. Poor diet and obesity go hand in hand, and all three can be associated with poor hearing or hearing loss and tinnitus. And this is an international effort. You'll find articles from around the world. There may be some articles in Russia that I'm not even aware of, linking diet and hearing loss. Here's one from Korea. These are often large studies, and they're based on tens of thousands, sometimes hundreds of thousands of people. So the connection between diet and hearing is very clear. It's not just a single study with a small number of subjects. Here's another study. The relationship between diet, tinnitus, and hearing difficulties. This is from the UK, showing that certain aspects of diet are most important in reducing hearing loss. For example, a higher vitamin D input. So if a person has an unhealthy diet, anything that can improve their diet is going to probably have a beneficial effect on hearing. We should be asking each and every one of our patients about their diet. In fact, you can actually have a patient fill out a very simple questionnaire. It takes 5 minutes. They should do it when they're completing their history. And that questionnaire will tell you more about their diet. You know, in a typical day, how many meals do you have that include vegetables, or that include red meat, or that include processed food? Of course, that's more for an unhealthy diet. So very quickly, you can size up a person's diet. And if you need to, you can get this information from their physician, or you can refer the patient to a dietary expert. I mean, you're not going to be modifying their diet with them, but some expert could do that. And the reason is it's going to improve their chances of preventing hearing loss or limiting the degree of hearing loss that they have. Here's another study, very recent. Dietary fat intake and risk of disabling hearing impairment. So there are many ways diet can affect hearing, and obviously fat intake, processed foods, other unhealthy dietary habits can have the biggest impact on hearing. Okay, so let's move now from diet, that's just one lifestyle factor, to another. Let's talk about smoking. Now, I've traveled around the world, and I know that not only in the United States, but in many other countries, including Russia, there are people who smoke very heavily, many packs a day. Many people would not link smoking with hearing. They wouldn't think of asking a patient, do you smoke? How long have you smoked? How many cigarettes do you smoke a day if you do smoke? But there are metrics called pack years. So a pack year is a person who smokes 1 pack of cigarettes every day over the course of a year. So a half-pack year would be somebody who smokes half a pack of cigarettes. A 2-pack year would be someone who smokes 2 packs of cigarettes. So we can quantify the amount of smoking, and there's a direct link, a very serious link between smoking and hearing loss and tinnitus. So if you were to ask me, again, if I were there in St. Petersburg and you said, okay, which of these lifestyle factors do you think you'd approach first with a patient? I'd say, well, if they're a heavy smoker, even though they may have a poor diet, note that's not uncommon, a heavy smoker with a poor diet, and even if they may have other lifestyle factors that could influence hearing, I would go for smoking first. We can get them to stop smoking. Not only will it reduce their chance of future hearing loss, believe it or not, for a person who stops smoking, hearing may actually start to improve. And this is true for heart function and also for pulmonary function. So a person who's short of breath, who has high blood pressure, who smokes, when they stop smoking, they generally get healthier in many ways, and including hearing may actually improve. So as an audiologist, one of my top goals is to make sure that I'm counseling patients as effectively as possible about what they might be doing to either prevent hearing loss or what they might be doing to increase the chances of hearing loss. I've got to take smoking into account. I've got to talk to them about smoking because the link is so strong. Here's another article. Is smoking a risk factor for tinnitus? Well, the answer is yes. Based on 700 peer-reviewed articles, this is a study from Germany, they conclude that yes, smoking is a big risk factor for tinnitus. And if we can get a person to stop smoking, we're well on our way to helping to manage their tinnitus. Here's another study, the effect of smoking on hearing. So the literature is clear. Now, there is some debate about how much smoking and if you do stop smoking, will your hearing improve? But the link between smoking and hearing loss, this lifestyle factor, is very clear. So diet, of course, exercise, we haven't even talked about that. That definitely is something that will reduce risk of hearing loss. And smoking cessation, stopping, never smoking, or stopping of the smoking habit are all ways to promote healthy hearing over the lifespan. Okay, we're now moving on to a very important topic, and we're going to get started on this topic, and then we'll stop the first part A of our, or part 1 of our lecture, and then I'll pick up again with a separate recording of part B. The reason I'm taking each of these big lectures, the Promoting Healthy Hearing Over the Lifespan lecture and my second lecture on objective measures of hearing in infants and young children, the reason I'm breaking them up into 2 parts is because I'm recording them, and the files are enormous. They're very many megabytes, over 200 megabytes. So they're very hard to send via email. They're impossible to send via email, and they're very hard to manipulate. So we'll have two part lectures. So we're about 50 minutes into the first lecture, and we've got just a little bit more, and then we'll take a quick break and start part 2 of promoting healthy hearing over the lifespan. So let's talk about how we evaluate patients to get the most out of our test results and have the best chance to promote healthy hearing. Well, let me just tell you at the beginning, we can't rely exclusively, we can't rely only on some of the basic, simple, old traditional hearing tests, such as pure tone audiometry. We need to expand our test battery, and we need to evaluate each and every patient depending on their chief complaints, why they're coming to see you, and their history. In other words, we don't just administer the same limited test battery on every patient. We have to customize or develop a test battery based on the patient's chief complaint, why they're coming to see us, and also based on their history, what we learn from the history about their other health status. This is very closely tied to one of the topics that I lecture on quite often, value-added tests. And I talk about this in that article that I mentioned at the beginning of our lecture. Value-added tests are tests that actually contribute, have a distinct contribution to the diagnosis of the patient and to their management. Now you might say, well, all the tests that I do will help me make the diagnosis. But in fact, some of the tests that you are performing with patients probably really don't help you that much. And then there probably are other tests, other procedures that you could perform that really would help, but you didn't perform them. You might say, well, I didn't have time to perform a speech perception and noise test because I ran out of time. Well, that's maybe the most important test that you should have performed. Maybe if the person's coming to see you because they're complaining of difficulty hearing in a restaurant and in noisy environments, maybe that's your top priority. Maybe that's the one test you should have performed. And maybe there are some other tests that really didn't contribute to the diagnosis. You didn't learn anything from the test, and you could have skipped those tests, deleted them, or not performed them, and saved yourself a little time to perform the speech perception and noise. So always ask yourself when you're about to evaluate a patient, will this test that I'm about to perform, will this procedure actually contribute to their diagnosis? Will I learn more about their auditory system? And most importantly, will this test that I'm about to perform actually help me manage this patient more effectively? Now, we're going to review a number of tests that people, audiologists, would tend to use in, or at least I would tend to use in many hearing evaluations. And we're going to critically evaluate whether each of these tests really contributes value to the test battery. So sometimes we may administer a certain test because it's quick and it still gives us all the information we need. Or maybe it's a little safer than another test. Maybe one option would be to perform an auditory brainstem response on a child, but to do that we need to have the child sedated or under general anesthesia. But there may be other tests that give us the same information without putting that child to any risk. So there may be different reasons for using tests, but always the primary reason should be it adds value to the diagnosis. It contributes to the diagnosis and to the management of our patient. Well, pure tone audiometry. Pure tone audiometry, which many of you rely on, most audiologists rely on day in and day out. Pure tone audiometry is not a very good hearing test. I know that sounds odd for me to say that as an audiologist, but pure tone audiometry is one of the weakest tests that we have in our test battery. It's got many serious limitations. So let's just consider them quickly. And this is all explained in the article I mentioned. Well, first of all, pure tone audiometry measures one of the simplest of auditory processes. That is, can a person detect a sound in silence? So they're in a silent environment, they're in a sound booth, they've got earphones on, and their only goal, their only task All they need to do is determine, is there a sound there or not? They don't have to know anything else about the sound. They don't have to process the sound. It's not a complex sound. In fact, we're having them listen to the simplest of sounds in the world, in their environment, pure tones, single frequencies. In fact, these sounds are so simple, the sounds that we're using for pure tone audiometry, a person never even hears them in their environment. You know, never, not once in my typical day-to-day or your typical day-to-day or your patients does a person hear a pure tone. Even sounds that, like a telephone ringing, for example, are really not a single pure tone. So this is a very unrealistic test. It's testing a very simple auditory process with a very, very simple sound. It doesn't have much of a connection or a relationship to the actual problems a person is actually experiencing day to day with their hearing. And not only do we only use single frequencies, pure tones, sinusoids, we only use 8 of them. 8 sounds, 8 frequencies. Now, the average young ear or person can hear pure tone frequencies from 20 hertz up to 20,000 hertz. And yet we're only sampling 8. I mean, if you said to a statistician, somebody who's a statistics expert, you know, am I adequately sampling a person's hearing if I sample 8 frequencies out of this range of 20 to 20,000? Well, I did the math. And between 20 and 20,000, there are 19,980 frequencies. Over 19, almost 20,000, of course. The only frequencies we're missing are the first 20 tones. And so 8 divided by 19,980 is, we're only evaluating 0.004% of that range. So even pure tone audiometry, which is so simple, using single pure tones, even that's weaker as a test because we're not sampling adequately. It'd be, if we were evaluating 1,000 of these frequencies, well, at least we'd have a pretty good idea of their pure tone thresholds. But we don't. We've got just a few data points. Plus, as I mentioned, pure tone audiometry just doesn't reflect real-world hearing problems. We don't listen to people in quiet, and we don't listen to pure tones. We listen to complex speech, where there are many frequencies and they're rapidly changing. And so the bottom line is that a person's audiogram has pretty poor correlation, poor relationship to their actual day-to-day problems with hearing. And so a person can have a normal audiogram or pretty close to it and have serious communication problems, and another patient might have hearing loss by the audiogram, at least in certain frequencies, but they don't really have much of a communication problem. So this connection between pure tone audiometry and why we're actually evaluating the patient is pretty bad. It's pretty poor. And then on top of that, that's a valid audiogram. But on top of that, many patients, the kinds of patients we've been talking about with, for example, cognitive decline, they're going to have problems with pure tone audiometry. And a patient who's not motivated to participate with pure tone audiometry, they may have an abnormal audiogram when they really shouldn't, but they're just not motivated to respond. They may have problems attending. They may have memory problems. They can't remember the instructions for pure tone audiometry. So even a valid audiogram doesn't give us much information about a person's auditory function, but very often the audiogram's not even valid with patients. We were talking about systematic reviews earlier. Here, and we were talking about cognitive impairments. Here's a great recent article. Can adults living with dementia actually participate? Give us a valid pure tone audiogram. And the question is very good. And patients with cognitive decline and dementia very often are not able to participate in behavioral audiometry. They're not able to produce a valid audiogram. So all I'm trying to say is move beyond the audiogram as you evaluate patients. The audiogram is not bad, but it's only one small piece of the puzzle. Now, we've talked about the limitations of air conduction pure tone audiometry. How about bone conduction pure tone audiometry? Well, all of the problems we just outlined for air conduction, the limited number of frequencies, actually even more of a problem with bone conduction. Now we only have 4 frequencies. And of course, all of the problems with validity in patients with cognitive impairment, the importance of motivation, attention, memory, those all affect bone conduction. And it takes time. You've got to keep one ear uncovered, put the masking in the other ear, evaluate the patient's hearing with masking. Then you've got to go into the sound booth, move things around so you're masking the non-test ear again as you switch from the right to the left ear or left to the right ear. It takes time. It takes more than 5 minutes. Now, it's not a lot of time, but in 5 minutes you could conduct a very thorough test of speech perception and noise. You could perform other tests that might give you valuable information. So here's the question. Are there patients who do not need to be evaluated with bone conduction audiometry? Are there patients where bone conduction pure tone audiometry simply doesn't add value to their diagnosis? Well, yeah, there are a lot of patients. If you, in an adult population, in an older adult population, people come to see you for possible hearing loss and they're over the age of 40 or 50. The chances of those patients having a middle ear dysfunction are very small. Very, very small, less than 1 in 100. So if a patient has coming to you and you say, have you ever had ear infections? No. Have you seen a doctor for any ear problems? No, I've never had any ear problems. You look in the patient's ear, the eardrum looks perfectly normal. They've come from their physician, maybe an otolaryngologist, but maybe a general physician, and this physician said there's no problems with the ears that we can see. And then you perform tympanometry, normal tympanograms. You perform even one acoustic reflex stimulus for one acoustic reflex measurement, and the reflex is perfectly normal. The chances of that person having middle ear dysfunction are 0. And the person doesn't have a problem with their middle ear. They've never had ear infections. They don't report any problems that required a physician to do something with their ears. Then why perform bone conduction? There's not going to be an air-bone gap. If there is an air-bone gap, it's not going to be valid. There's no reason to perform bone conduction pure tone audiometry on a patient who's not at risk for middle ear dysfunction. Tympanometry, yes, we're going to talk about that in a moment, but not bone conduction. So in my career of over 40 years, I will never perform bone conduction audiometry unless it adds value, unless there's a reason. And I will save that time and utilize that time for tests that do add value. How about speech reception threshold? There's another traditional test, finding a person's threshold for usually 2-syllable words, spondee words. Finding a person's the lowest intensity level at which they can just hear that there's some speech and repeat the words. Well, we routinely do it, but if we already have a pure tone audiogram and we have no reason to think that the pure tone audiogram is inaccurate, if the person's pure tone audiogram is showing perhaps a high frequency hearing loss and they are responding very, very well, and we have other test results which confirm the audiogram, maybe tympanometry shows that there's no middle ear problem, no air-bone gap. Maybe otoacoustic emissions are showing that they're abnormal, right where the patient has a hearing loss on the audiogram. Then speech reception threshold just doesn't really contribute much. It doesn't add value. And I've done some research on this, showing with over 1,000 patients, showing if a person's got intact, I mean, they can understand the instructions, they're working, they drove to the clinic, they're intact in terms of cognitive function. Maybe they have normal hearing sensitivity in the low frequency, so you know you can get accurate thresholds. And they're somewhere between the age of 20 and 70, then the speech reception threshold is really a waste of time. It adds no value. So you can save another 5 minutes. So between saving the 5 minutes for bone conduction pure tone audiometry that we didn't need on most patients, and now another 5 minutes we're saving on not doing speech reception threshold, now we can actually evaluate the patient in ways that probably are going to help us to diagnose their hearing loss and manage. So what test could we substitute for speech reception threshold when it doesn't add value and bone conduction pure tone? Well, one is speech perception and noise. In an adult population, certainly many children, but in an adult population, many of our patients are going to have come to us with complaints about hearing and understanding people in noisy environments. So here's a test that really does contribute. It actually is related to why they're coming to see us. It will give us information that will help us manage that patient more effectively and counsel that patient. And speech perception and noise tests are much more likely, have much more correlated with neural problems like vestibular schwannomas. That they're going to have problems with. Patients with vestibular schwannomas will have difficulty with speech perception and noise, where they may not have problems that are going to be detected with other tests. And certainly, we've already talked about this. One of the earliest indicators of cognitive decline, cognitive impairment, and dementia is problems with speech perception and noise. So this is a test that almost always does add value to your diagnosis. Okay, I was going to go a little bit further, and I will, but we are well over an hour, so the second part of this lecture probably will be less than an hour, just to give you a little rough idea. Let's talk about one of the two objective auditory tests that almost always do add value. And I suspect that many of you in your clinical practice do not routinely perform these tests in every patient. And I'm going to encourage you to utilize each of these objective tests more often, even in adult population, not just children. And the two tests are oral emittance measurements, and by that I mean tympanometry and acoustic reflexes. And the other objective test that I've routinely included in my test battery since it was available in the 1990s is otoacoustic emissions. Let's just quickly review oral emittance, and then we'll come back to OAEs at the beginning of part 2. Well, if you're trying to evaluate middle ear function, the eardrum, the ossicles, and how well they function, there's no better measure than oral emittance. You're measuring middle ear function directly. It's a mechanical measurement of the middle ear. It's not an indirect measurement like comparing the air conduction and bone conduction pure tone thresholds. So these are very sensitive middle ear problems. In fact, if the tympanogram is normal, nice, what we would call a type A, and if the acoustic reflexes are present at normal levels, you can pretty much be assured with 100% assurance that there's no middle ear problem. The middle ear is normal, and there's no need to go on to bone conduction. Now, we've known this now for 50 years. Since the early 1970s, my mentor, James Jerger, started publishing articles on large numbers, over 1,000 patients, showing middle ear measurements like tympanometry and acoustic reflexes are extremely sensitive and very valuable in diagnosing hearing loss in patients. You can quickly rule out or confirm conductive or mixed losses by performing oral emittance measurements in a matter of just minutes. The equipment for performing oral emittance dates back to the early 1970s. And by 1975, Dr. Jerger had edited a book on this topic. So we're talking about an evidence-based approach to hearing assessment, auditory assessment, that's objective, that can be performed in any patient from an infant to an older adult with cognitive decline. It doesn't require any kind of behavioral cooperation from patients. So it has all of the advantages of an objective test. Now, very quickly, you may be measuring impedance, or you may be measuring admittance. Most modern devices, such as the one shown here, the TimStar Pro, are really measuring admittance, which is the ease of energy flow through the middle ear. In the early years, we're almost always measuring impedance, which is the opposition to an acoustic energy flow through the middle ear. But either way, we now typically use the word emittance, which is kind of a combination of those two terms, impedance and admittance. But it is the most sensitive measure of middle ear function. Now, you can get a lot more information from oral emittance than simply recording a tympanogram. Obviously, you can calculate ear canal volume. You can determine whether or not the the eardrum is intact. You can measure the static compliance or flexibility of the ear at rest, at atmospheric pressure. You can perform tympanometry, and you can actually measure how well the eustachian tube is functioning and whether or not the middle ear is functioning normally. And then, of course, there are the acoustic reflexes. So within this category of oral emittance, there are actually many, many measurements. Now, we're going to move through this pretty quickly. I will come back to talk a little bit about these objective tests when we discuss evaluating infants and young children. You're all familiar with tympanometry. The main point here I will make is that with infants under the age of 6 months, your tympanometry should be performed not only with the 226, the lower hertz probe tone, but also with a higher frequency probe tone, such as 1000 hertz. I should point out there are devices on the market that you can probably see at the conference in the exhibit area, which are capable of performing another form of middle ear measurement called wideband reflectance or wideband absorbance. So it's similar to tympanometry in the sense that you're getting information on the middle ear, but there are some distinct differences. One is that because it's a wideband stimulus, like a click, you're getting information on how the middle ear functions for many, many frequencies very quickly, rather than just 1 or 2 probe frequencies. And the second advantage or distinction is that you don't need to have an airtight seal, a hermetic seal with the ear canal. You can perform wideband reflectance and absorbance without an airtight seal. And research over the last 15 years or so has clearly shown that there are distinct patterns for wideband reflectance or absorbance for different types of pathology and, of course, for the normal ear. So in some patients, wideband techniques will give you more precise information on the actual pathology or the actual abnormality that's affecting the middle ear. So for the most part, traditional tympanometry and wideband reflectance provide the same good information on middle ear status. Now, as you know, there are middle ear muscles. There are 2 of them, the stapedius muscle and the tensor tympani muscle. For the most part, we're interested in recording the activation of the stapedius muscle, not the tensor tympani muscle. The stapedius muscle is the smallest muscle in the body. It's innervated by the facial nerve, as you all know. So this is the muscle that we're actually utilizing when we're recording acoustic reflexes. We're not really interested in the muscle, but the muscle, of course, is the stapedius muscle is connected to the stapes, and therefore when it contracts, when the stapedius muscle contracts, it radically reduces the compliance of the middle ear very quickly, and so we know that the acoustic reflex has occurred. So we're measuring the stapedius muscle activation when we record acoustic reflexes. The tensor tympani muscle, we don't think about much very often. It does play a role in hearing, particularly the startle response to very loud sounds. It's innervated not by the 7th cranial nerve, the facial nerve, but by the 5th cranial nerve, the trigeminal nerve. So for the most part, we kind of ignore the tensor tympani, but it may play a role in certain types of tinnitus, particularly intermittent tinnitus that some patients complain about in one ear. Now, to really utilize acoustic reflexes clinically, you need to understand the pathways, the different structures involved in the acoustic reflex pathways, or the acoustic reflex arc. There's the auditory nerve is the afferent portion. There are numerous centers and neurons in the brainstem that are involved both in the ipsilateral and contralateral reflex. And then the facial nerve is the efferent portion of the acoustic reflex arc. So this is, we're not going to talk in detail about this, but it's very important to understand these pathways in order to utilize acoustic reflexes clinically. Now, there are at least 4 different acoustic reflex measurements that we could make. And the very first was described back in the 1970s by Dr. Jerger and others. That's the acoustic reflex threshold. The other 3 measurements, though, can be made with current equipment, with equipment that you could purchase, and they have value. They go beyond acoustic reflex thresholds. They're more sensitive to auditory function than the acoustic reflex threshold. So we're going to quickly talk about each of these, and then we'll take our break. Well, you all know about acoustic reflex threshold. We present a stimulus around 80 dB. If there's no evidence of change in impedance or compliance, admittance, then we go up in intensity, maybe to 85 dB. And when we start to see a change in compliance, we know we've elicited the acoustic reflex. And we could go a little higher to be sure that that's the actual acoustic reflex threshold. But it's usually around 80, 85 dB for tones, and it's usually about 20 decibels lower, 60, 65 dB for broadband noise. Now, I've always used separate ear audiograms. So I've got two audiograms, one for the right ear, one for the left ear, but they're all on one graph. And if you do that, you have room to plot the acoustic reflex thresholds because you have very few symbols for each ear. You're using the same symbols for the right and left ear. You know which ear results are the right ear and left ear because they're on separate graphs. And if you plot the acoustic reflex thresholds on the audiogram, as I always do, and as you see here, the arrows are pointing to the acoustic reflex thresholds. They're a different symbol than the pure tone thresholds. And you can actually see whether or not the reflexes are at normal levels and whether there's loudness recruitment. That is, reduced intensity level between threshold, person's auditory threshold, and their acoustic reflex threshold, as you see here. So plotting the acoustic reflexes on the audiogram and plotting whether they're normal or abnormal helps you to interpret the reflex findings and actually helps you make a diagnosis. So this is something I would recommend for every patient, not just for patients with certain problems. Acoustic reflex amplitude is the other measurement that any of you could make. You just simply find threshold and start going up in an intensity 5 dB increments or 10 dB increments and evaluate how rapidly does the amplitude of the acoustic reflex grow with increased intensity. And this was actually the topic of my doctoral dissertation, my PhD dissertation in 1979, acoustic reflex amplitude. And I showed that it's very valuable clinically. I published 5 papers based on this dissertation in international journals to show that any audiologist who can record acoustic reflexes can also document acoustic reflex amplitude. So this was from my dissertation. The stimulus will have an effect on the amplitude. Male versus female gender, believe it or not, females have large acoustic reflex amplitudes than males. That was statistically significant. Advancing age, older people have lower acoustic reflex amplitudes compared to younger people. So it's a very sensitive measure. Even in people who have the same acoustic reflex threshold, the actual amplitude at higher intensities may be different depending on age and even central auditory functioning. So I encourage you to go above the acoustic reflex threshold, present higher intensities, you'll get a lot of valuable diagnostic information. Acoustic reflex decay, you're all familiar with. We don't use this very often, but if you have a patient with unilateral hearing loss or asymmetry, you have a patient where there's some concern about a retrocochlear abnormality on one side, this is a quick, obviously very quick and easy test that will help provide you with more diagnostic information. So it should be part of your test battery. Utilize it as needed to document retrocochlear abnormalities in your test battery. You present the stimulus, as I think you're all familiar with this, for 10 seconds. And in a person with a normal middle ear, normal cochlea, normal auditory nerve functioning, the change in compliance or admittance will be maintained for all of that 10 seconds. In a patient with acoustic reflex decay, the admittance comes back to baseline within that 10 seconds. That's a retrocochlear finding and it would warrant referral to an ear, nose, and throat doctor, preferably an otologist. And then the very last topic I'm going to discuss, and then we'll stop, is acoustic reflex latency. That is, how much time does it take between presentation of the stimulus and then the beginning of the acoustic reflex? How much time does it take for that signal to go from the ear, up the auditory nerve, through the brainstem, and back down to the stapedius muscle, through the facial nerve? Well, this acoustic reflex latency was first described in the 1970s, but all of the data that were collected back then were invalid. They were invalid because the equipment being used was analog equipment and it had a lot of delay It was delayed in its response. See, the piece of equipment couldn't faithfully and quickly respond to the stimulus and produce accurate measures of latency. So up until recently, acoustic reflex latency was really not even considered in performing a diagnostic assessment. But modern pieces of equipment, and this is from the TIMSTAR Pro, GSI TIMSTAR Pro, have this feature, acoustic reflex latency test feature, where you present the stimulus as you would to record acoustic reflex with any patient, and then you will automatically get calculations of the acoustic reflex latency, the time between the presentation of the stimulus and when the acoustic reflex begins, when the reflex reaches its maximum point, and then when it finally gets back to baseline. So we now have a clinically feasible, very accurate measure of acoustic reflex latency that can be used in the diagnostic evaluation of patients if you suspect any problem affecting the auditory nerve or the central auditory pathways. Okay, we're going to stop here for part one, or the first segment of this lecture on promoting healthy hearing. When we come back, we'll talk about otoacoustic emissions, and then we'll talk about how this information can help you manage the patient and actually prevent hearing loss or mitigate the development of further hearing loss.